Morning everyone, and welcome to the Leicester, Leicestershire and Rutland Joint Health Scrutiny Committee on the 27th of November 2024. I'm Councillor Karen Pickering and I'm chairing the meeting today as Jonathan Morgan has given his apologies. Mr. Phil King is subbing for Jonathan Morgan. We also have apologies from Councillor Steve Bonham and Liz Sahu and Janet Underwood. The meeting is being broadcast live to the public via YouTube and will be available for viewing on YouTube after the meeting. Please turn your microphone on when speaking and turn it off when you've finished. We're not expecting another fire alarm, but if a fire alarm does go off, please exit via the committee room via the door you came in, turn right, go through the double doors and down the flight of stairs which leads to fire escapes. Minutes of the previous meeting. I'm aware that Janet Underwood was missed off the attendance list. Are there any other amendments? Okay, I proposed the last meeting's approved, subject to those amendments. There are no questions from the public, no questions from members. I've not been notified of any urgent items. Are there any declarations of interest in the agenda today? Yeah.
Many thank you, Chair. Members may recall previously I had a declaration of interest working as a dentist, providing NHS services in Derby and Nottinghamshire. Earlier this week I got a contract to start a position at the Office of the Chief Dental Officer, which is under the remit of NHS England. And whilst that's separate from the Department of Health and Social Care, who's going to make the decision on potentially water fluoridation in Leicestershire, I just wanted to be clear on that.
Thank you very much. And we've not received any petitions, is that right? Okay, so we're going to receive a verbal update from Dr. Neil Zangani, Chief Medical Officer, Integrated Care Board. Also here answering questions will be John Melbourne, Chief Operating Officer for UHL, and Tracy Wood, Assistant Director.
Morning, thank you everybody. So this is just really a verbal update on the critical incident that occurred at University Hospitals of Leicester, and I've got John Melbourne, as you say, Chief Operating Officer from UHL with me this morning, who will, I'm sure, contribute. So on the 9th of October this year, UHL was receiving very high numbers of patients, and the pressure in the whole system, so primary care, ambulance service, our community services, as well as the hospital trust, was reaching full capacity. We decided to declare, well, UHL decided to declare a critical incident on that day due to the extreme pressures. Critical incidents enable us to take different actions to usual business as usual, calling in extra support from our clinicians to work extra shifts and provide additional care to manage the emergency pressures. So I'll pass on to John to describe a bit more about the actions we took and the consequences of those decisions. Thank you, John.
Thank you all. I hope you can hear me. Excellent.
Yes, we can hear you, John.
Thank you. So firstly, I'm very sorry I'm not with you this morning. I had an urgent meeting which couldn't be rearranged at the Leicester Royal Infirmary, which meant I couldn't get across to you in time. So I am sorry that I'm not with you in person. Neil's described the scenario on the 9th of October. Firstly, to describe the exit point, we exited 30 hours later at around midday the following day on the 10th of Wednesday. It did allow us, both as a trust and as a system, to put in place additional actions to get more people out to the right place for their onward care more swiftly than we usually would do, because it allowed us to, as I say, bring in extra colleagues, bring in extra capacity across the system for this scenario. We were facing incredibly, really significant pressures on those days and in the days leading up to that position. That meant we declared at that time. To be clear, we have not declared a critical incident since. We do remain challenged as a trust and as a healthcare system, and that will remain the case, of course, going through the winter period. We're still seeing a lot of demand through our urgent and emergency care services. But again, I'm very grateful for the support of system colleagues in supporting us through that incident, and indeed every week there since. I am aware of the messaging around declaring a critical incident. We are clear about the triggers that lead us to do so, and we work very closely with system partners in doing so. I'm very happy to answer any questions on the critical incident or otherwise. Thank you.
Thank you, John. Nilesh, do you want to say any more, or should we go straight to questions?
Just one further point, I suppose, in terms of, and it may be a question that people want to understand, is the drivers for this, what was causing this. So the data is suggesting increase in respiratory illness, but also what we are seeing is increased complexity of our patients. So we have 3 times as many patients in hospital now with 4 to 5 long-term conditions. So the complexity of our patients is difficult. But I think this was, although the University Hospitals Leicester declared a critical incident, this was whole system pressure across all of our NHS and social care partners at that time.
Thank you, Nilesh. Are there any questions from Councillor Hack?
Yeah, well, we spoke earlier on this month, on the 5th of November, at the Health Scrutiny at Leicester, and you were still waiting money for the winter plan. And there was a decision yet to be made on what the winter plan was going to look like. Has that been finalised now? And is there a proper plan in place? And do you have the staff available to cover that plan?
Yes, so we have agreed a set of some 10 or more additional interventions. This includes additional funding for general practice appointments, urgent treatment centre appointments, many of our mechanisms out of hospital to reduce flow into hospital, so supporting our ambulance service to be able to have direct conversations with consultant colleagues and other community partners to avoid conveying patients to hospital, as well as some additional beds. So those plans have all been agreed in principle. We are a system in significant financial pressure, so we have to make sure that we can utilise that funding as efficiently as possible without causing extra pressure elsewhere. We are also currently experiencing extreme pressure across the Midlands, not just LLR. So East Midlands Ambulance Service are under extreme pressure with some record numbers of calls. So we are literally in almost critical incident territory at the moment in the way we are operating because of the pressures on our ambulance service. And so we have decided to enact some of those additional winter interventions early to make sure that we can support our ambulance service, but also our wider system.
Thank you, Nilesh.
Can I come back to the question?
Yes.
Thank you. A couple of points that you've raised. How much is the deficit currently in the ICB? You mentioned the financial pressures you're under, and also the ambulance delays. I mean, one patient was in an ambulance for 16 hours on the 8th of October. And only a couple of weeks ago, only a stone's throw away from here, 5 o'clock in the morning, somebody had a stroke, called 999 for an ambulance. It was a 2-hour wait before the ambulance got to him. And in the end, they just took him down to the hospital, to the Royal Infirmary. It took another further 24 hours for them to get a bed. What is actually going on, and why is the system just so broken here?
So those situations are absolutely unacceptable. They're not something that we want any of our citizens to experience. We absolutely want to apologise for any poor experience or poor care because of the pressures they're experiencing. And I think all partners would absolutely take that position. The pressures they're experiencing are not unique to Leicester, Leicestershire and Rutland. As I mentioned, across the whole of the Midlands at the moment, we have many systems either close to or declaring critical incidents. The pressures are extremely high across the piece, and it goes beyond the Midlands too. We definitely have an increase in demand across all of our services. We have some really good public health data demonstrating the increase in demand across primary care, community hospitals, secondary care, EMAS, all of our services. I also referenced the point about complexity. We have patients living longer now with a lot more long-term conditions, and that actually means that when we're treating them, we're not just treating one condition, but we're treating underlying problems as well. We have an aging demographic with increased frailty, so it's multifactorial. But I really want to just emphasise that we are doing everything we possibly can to get the right care to the right patient in the best possible way. We absolutely understand that the experience of our patients at the moment across the urgent emergency care pathway is suboptimal, and that's to say the least at times. But we are doing everything we possibly can, and all partners are working together. In terms of financial position, Councillor Hack, we will declare that through our public board, but we did submit a deficit position this year, a significant deficit position, and unfortunately we have an adverse variance to that plan already because of the pressures that we're seeing across the whole system. But in terms of the precise details, I would refer you to our public board papers for that.
Can I just ask, is it 80 million or is it 88 million? That's what was in the public domain.
So 80 million is the deficit plan that we have agreed. And as I said, we're already running an adverse variance which we presented in our next public board in early December.
Thank you, Nilesh. I believe Dan Harrison has a question.
Thank you very much. Well, we're all saddened to hear of the problems you're facing, obviously. However, we understand you have winter planning. So there is programmes in hand and resource made available, one would presume, through that. So this conflicts with all of your planning, or was your planning not at a level that looking at what was happening and understanding how the reactions, because you're living with all these stats all day long, you know, how many people are going in on a regular basis. So just try and explain how your winter planning was obviously not anywhere near the game to be able to cope when you had this incident. Thank you.
Can I come in on that point, please?
I understand. Yeah, John's got his hand up. Sorry, I didn't get to the button in time.
Sorry, thank you. So it's a very fair question. So firstly, we as a trust, UHL, but also as a wider system, we do our urgent and emergency care plan every year. So we don't just plan for winter because we know we see pressures across the whole year linked to urgent and emergency care. We also, within that, have winter plans that aim to deal with the demands we see during our winter period, and we took those through both the ICB board and our trust board within the last month or so. Councillor Hack and Neil have already referenced some of the additional initiatives that we are hoping to put in place within the next couple of weeks, linked to the increases in demand which we are seeing. That said, alongside that, we are seeing demand above what we had initially planned for this year. So of course we look every year at demand projections, but we are seeing some demand both in terms of attendances and admissions that are above what we'd have expected, which is why we are putting in place additional interventions. However, like Neil has also referenced, we have financial challenges as well, and we have to make sure we're using the best use of our money. And there are times when the variability we see in urgent emergency care demand can lead to really significant pressures, and sadly people waiting on ambulances, for example. So I don't think it is a sign of weak winter planning, but what it is a sign of is increase in demand. Some areas where it is really challenging to be able to cope with the level of demand we are seeing across the system that aren't just financially driven. They're linked to the capacity of all of our services across the system.
Thank you, John. I believe Ross wants to come in. Ross Hills.
Perfect. Thank you, Chair. I want to start off by recognising that you've got a really difficult role. I appreciate taking no pleasure at all in having the budget deficit there. I think what I'm concerned about, though, is that the descriptors that you used for the cause of the critical incident are, increased medical complexities, whole system pressures, that these are standard across the entire East Midlands, if not national. But to me, a critical incident should be something that is brought about by a specific incident. I understand during Christmas when they usually occur, staffing levels are probably lower. You're more likely to get respiratory illness then. So I think it's really worrying that I don't recall having a critical incident this early in the winter. And I think it's been relatively mild up until the last few weeks as well. So am I right to presume then that these are just going to become more standard across the board, more common, these critical incidents? My second question is, just curious, if we declare a critical incident, does that unlock any additional support or funding from maybe the Department of Health and Social Care? Or is it, we're purely on our own, really?
So a really good challenge. And actually, what we are seeing is an earlier presentation of respiratory illness. So currently, I describe the pressures that we currently have this very week. We are seeing very high rates of respiratory syncytial virus. That's the bug that every order patients can actually get vaccinated against now. We're seeing lots of norovirus, and we're seeing it earlier in the season than we formerly would have done. So there is some sort of seasonal change that we are seeing in terms of respiratory viruses, which have a big impact on our patients with heart disease, respiratory disease, and other complex and long-term conditions. But I think what we're also seeing is increased demand throughout the year. So John talked about not just winter planning, but urgent and emergency care planning. What we are seeing is sustained demand throughout the year. So formerly, we would have seen some sort of lull in the summer where respiratory viruses and things seem to improve, but our activity seems to be high throughout the year. So we are running on a higher baseline continually, and then it doesn't take much in terms of either viral pathology or other pressures to tip us over. So at the moment, we've actually got huge numbers of children attending our emergency department. So we have a paediatric issue at the moment there. Critical incidents allow us to focus in on the pressure that we have at that time, to potentially stand down some routine care, to bring other resource in, to take actions as a system that we wouldn't normally want to take, which can have adverse consequences. Remember, we're not just running an emergency care system, we're running a planned care system, mental health, primary care, pharmacy, optometry, dentistry. So we're trying to keep everything going here. And so our balance in winter and emergency care planning has to be a balance between how much resource we put into that part versus everything else that's going on in our system. Unfortunately, it doesn't unlock any resource from any other sources. It's how we manage it internally.
Thank you, Nilesh. Ross Hills. Oh, sorry, Phil King. I was looking at you.
I did think that. Okay, thanks, Chair. And I've listened very carefully to what's been said. And having been a member of this committee previously, I'm just subbing in today for Mr. Morgan. But I just think this is something that, some of the stuff that's been said, they are things sitting here thinking, well, you said that before. You said that a few years ago. You said that a few years before that. And it seems to me this is kind of a continual thing. And what I'm concerned about is that nothing is being done to address the fundamentals of the issue, which to me seems to be that in Leicester and Leicestershire, you've got essentially a central A&E in Leicester City, that you've got limited access for people in the county and in the city to access their own GPs out of hours. The provision of out of hours is, as you mentioned, complicated. It's very complicated. Patients, residents, taxpayers, at the end of the day, we're all paying for this, don't understand. And so they go to route one. And route one is to turn up at A&E in Leicester because they know it's open 24/7. And they know that someone will be there. And eventually they will get seen. It might be hours and hours, but they will get seen. And they turn up for all sorts of minor things, from wanting a sick note, I'm sure. I know that because I was there when someone said that, sat in front of me, to, very complicated, complex issues, life and death situations. And don't doubt the hardworking professionalism of all the staff involved in, dealing with patients and dealing with the situations. But to me, there does seem to be a fundamental problem here that is not, or so far has not been addressed. And I accept there is increased demand and there's all sorts of other things going on with people living longer and people having high levels of health anxiety about the most minor of sniffle. They think suddenly they've got to turn up at hospital. So I'm just wondering what's been done and whether there is any evidence from elsewhere to show that actually diverting people away from attending A&E, presenting themselves to hospital for a sick note or a cold, what turns out to be a cold, and what's been done to get them to go to, some other route, and what success, because I'm not hearing as much about that as I used to, and that's concerning. So I think it is very difficult, and but then just picking up your other point, and I'm sure we all know this, is that there's knock-on impacts. So if you have very high level of demand on A&E incidents, then essentially you're having knock-on impacts on the planned care, which then just exacerbates the already extreme waiting lists, rationing that's going on to patients who are, maybe not at the top of the list for the clinical need, but as far as they're concerned, they're top of their list at their individual level, and they have a lot of anxiety and stress about their individual situation. So I think, to me, I'm concerned about this, the fundamental issue, is that being addressed, or are we just, excuse the expression, kicking the can down the road and just, firefighting literally from, month to month, week to week sort of situation? Thank you, Chair.
I believe John's got his hand up.
Thank you. If I might start, Neil might want to add. So firstly is, I think they're all very fair points, Mr. King. Thank you for making them. Of course, today we have focused on the short-term critical incident plus the interventions for this winter. I think perhaps at a future committee it might be worth us coming back with our longer-term plans. I think clearly we have been seeing increases in demand. It is fair to expect that those increases will continue if we don't do something differently, as you say, and we are committed to thinking transformationally about how we design urgent and emergency care to give the best care for patients in LLR. And I think that will look at doing things differently across our emergency care pathways. And I think recently we've got Julie Frake-Harris, who's our System Director for Urgent Emergency Care. We've got a Clinical Director for Urgent Emergency Care. I think coming back, who've just started, I think coming back with a plan around that and explaining to you what we are doing more transformationally long term, I think would be really helpful, actually. I think we are all aligned that we do need to do something different in the long term, because just continually dealing with X% more demand every year is not a sustainable solution, clearly. Alongside that, with planned care, again, absolutely recognise the links to urgent and emergency care. In 2023, we delivered nationally leading improvements in our planned care, and we've continued progress this year in bringing our longest waiting numbers down. And we recognise we've got to do both together. Again, we have seen improvements in urgent and emergency care. What we've seen alongside that is big variations in demand and increases in demand.
Nilesh.
Yeah, thank you. And I think it's such a wide piece because it's also interrelated. So just a few points. Some of those patients on waiting lists that you described will end up in urgent emergency care if we don't treat them. So this is the balance that we're talking about here. So I think that wider discussion in terms of what we're doing in the planned care arena, the routine care arena, is really important there. We have significantly increased our urgent treatment centre capacity and the hours of operation. We're literally in the process of reviewing our same day capacity for general practice. We go over and above compared to some systems in terms of what we provide for same day access for general practice. We're one of the leading systems actually in the utilisation of pharmacy first. So there's multiple conditions now where antibiotics and treatments can be prescribed by pharmacists in pharmacies, and we're actually streets ahead actually in terms of the numbers of patients going through there. So we have definite evidence of lots of improvements in terms of activity and numbers. We're doing quite radical things. So patients who are of lower urgency calling through to an ambulance, or you would call them category 3 to 5, our lower urgency patients, are now being diverted away from an ambulance, getting a community response. So we're managing our ambulance tax by that way. And we've got lots of evidence of all those improvements, but it's almost like we're chasing our tail to keep up with it. And that's why I think the prevention agenda and the long-term condition management piece that I'm trying to reflect in this conversation is equally as important. So patients on a cancer waiting list who could deteriorate in that time could end up on that pathway. So for us, it's really important we get that balance right. Access to mental health has improved enormously. We've got crisis cafes, we've got all sorts of other interventions that don't need to actually use our mental health services when people are in crisis. We are triaging a lot more patients to get them to the right place at the right time. We want more patients to be using the NHS app to reducing contact with their GP practice, for example. The list of interventions goes on and on. So it's an interrelated piece, and we can't just see it through the lens of urgent care because everything is so dependent on each other.
Thank you, Nilesh. I think it's that knowledge that it's really difficult to deliver at capacity as well as making long-term plans, and that prevention agenda is critical. Councillor Ramsey Ross. Oh, sorry, do you want to come back and then I'll come to you?
If I may, Chair, thank you. They've offered to bring back a report. I think that would be a very good idea. And I'm sure that the committee, obviously I'm not a regular attendee, but if I was, I think that's something I would welcome. And I do hope that can be brought forward in due course. Thank you.
Thank you. And I'm sure you've got that, haven't you, Ewan, to bring it back? I think that's a good idea. Councillor Ramsey Ross.
Thank you, Chair. I wonder if you could say a little bit more about the position with regard to the ambulance service, because we did receive a very pleasing report just over a year ago about the improvements that we'd actually seen. And I'm assuming from what has been said that essentially we're in a position where the forecast of demand is simply wrong. So that's my first question. The second question relates to the winter preparedness plan, where the focus in terms of asset utilization is still predominantly focused on LRI, and I apologise, I can't remember the second facility. And this committee made a comment, I think it was back in February last year, about this issue about asset utilisation, and we pointed, by way of example, to the lack of utilisation of the Maryland Vaz facility. So I'd like a specific answer on what the medium-term plan is to provide alternative facilities out with those measures that you've taken within primary care. Thank you.
Yeah, thank you. So a really good point. And that's actually a really fundamental principle. So it's not always about just increasing our capacity, it's the best utilisation of it. That's a really important thing. We often talk about failure demand, which is where we have demand from a patient and we don't get them to the right place at the right time and they bounce around the system. That's a failure of our demand management. So some of the interventions we're taking now are really supporting our emergency department to manage those patients who've come to the ED, the emergency department, who don't need to be there, to directly book them into urgent treatment centres or other services across our system. We're doing the same with our urgent treatment centre. So 111, if a patient calls, can be booked directly in. And we are trying to increase the proportion of those appointments where patients can be directly booked in. So they're not bouncing around the system, as it were, and having to turn up to one place, be told to go elsewhere. That's really important. We will never change that completely. There's human nature and there's also understanding of what's available. It is a complex system. I think it was referred to earlier on. So we have some of our urgent treatment centres with X-ray facilities, others with not. So it is complex. But we are trying to, through 111 and through the navigation that we're doing, is get those patients to the right place in the right time. So I think that's an important utilisation of the assets across the system. We are, from the ambulance point of view, we are massively trying to help our ambulance service to manage those patients who don't need to be calling an ambulance. So it might be through frustration, it might be through anxiety, whatever the reason is that they're calling an ambulance, they think that's the right disposition for them. But we have real success stories of patients being managed by community nursing teams, by our home visiting team, by our DHU colleagues, Derbyshire Health United, actually keeping patients out of hospital. And we have a significant rate of maintaining patients out of hospital 28 days later after that sort of intervention. So we are absolutely focused on process improvement and best use of the resource that we have, as well as that additional capacity that we've outlined.
Thank you, Nilesh. Any supplementary? No? Okay. Time is rolling along, so I'm going to come to Ross Hill and then Councillor Hack.
Perfect. Thank you, Chair. I'll be concise then. You mentioned the internal benefits that declaring a critical incident has in terms of staffing levels and diverting resources. It obviously also has an external benefit as well. You know, I see it very well publicised and the communication is very good in sending out the messages for patients maybe to divert away from the emergency room if it's not an absolutely emergency, which has the benefit. Have we seen, though, if we're declaring these critical incidents more regularly, have we seen patients be desensitised to that messaging?
It's a really good question, and I don't think we have the answer to that at the moment. We also have to be very balanced in our messaging, that we don't cause some of our patients to take the wrong action. You will recall in the pandemic that some patients actually were having a heart attack or a stroke and didn't present to our emergency services. We don't want that to happen. I've done some of the media on this with colleagues in the room, and actually we're very clear that if a patient feels they have an emergency, we want them to use the services appropriately. We don't want to have people feeling scared or intimidated into using the resources that are available. It's a really important point, and we have to make value judgments on whether it's right to do that. And what we're trying to do, we have something called a Get in the Know campaign in LLR. We're trying to really promote that. It's a simple website, recognise that not everybody can access the website, but for those who can, it absolutely supports you to find the service most closest to you that's going to be the most beneficial for you. We know how frustrating it is for a member of the public to be able to get access to the right service in a very long queue and then be told you're in the wrong place and this is not the right place for you. So our Get in the Know campaign, which is widely publicised through our social media channels and on our ICB website, is fundamental to supporting our patients to get to the right place. But we have to get the balance right, I think, in terms of the messaging, and we don't want people to not use services where they need them.
Thank you, Nilesh. John, did you want to come back?
Thank you. Just two very brief points. So one is I absolutely agree communications is fundamental. We know we have people in our emergency department and other services every day that don't need to be there. We want to prioritise it for the people that do need to be there, like Nild has described. Just on the point of the incident declaration, I don't believe it has lost its impact, and I think we can evidence that when we have infrequently declared, which is an average of around, forgive me, don't quote me directly, I need to check, but an average of around one a year for the last 3 years. We are not an organisation that declares incidents frequently. We've got a very clear policy which defines when, and our process for doing so, and the Integrated Care Board have the same.
Thank you, John. Councillor Hack.
Yeah, first of all, I just wanted to mention how fantastic the staff are across the NHS and what a brilliant job they do, because lots of patients feed back to me and say, look, they were brilliant, the ambulance staff and everybody else. But the real problem is that if you dial 999 in a timely manner, you're not going to get an ambulance. I've had people contact me, somebody broke their hip back in April of this year, 80-year-old lady in the kitchen, she was lying on the floor for 9 hours waiting for an ambulance, and recently heart patient was a 5-hour wait. As I said 3 weeks ago, a 2-hour wait for a stroke patient. You can't have that. This is the critical service, a 999 service that you're calling in an emergency, in a panic. Nobody else might be there, and you're calling up somebody for help in an emergency. And the problem is the ambulances are stuck outside the A&E department. A few weeks ago, I was there, and there was 12 ambulances queued up, 2 crew in each of those ambulances. The cost of those is almost something like £1,000 per hour. So if you have 10 crews there for 10 hours, that's £10,000 you're losing per day. They need to be back out there on the road. And when I speak to staff, they say, we don't want to be working in an ambulance 12 hours a day. That's not what we signed up for. We signed up for getting patients back into the hospitals and then going back out there to pick up more patients. And they do a fantastic job. They've got one of the best conveyancing rates in the country, meaning they look after patients better at home and keep them at home better than anybody else. That's such a valuable resource that is totally being wasted by the Integrated Care Board, and the hospitals need to look and see what they do about this. The reality is, even the walk-in centres, they're not walk-in centres. Where, there's a joke around in Leicester. When is a walk-in centre not a walk-in centre? When it's in Leicester. Because you can't walk into Oadby, you can't walk into Merlin Vaz and be seen. They'll say there's no appointments available, go away. And where do they go? A&E department. That's where they go. What is the ICB really going to do when they're £80 million in deficit? You're looking at saving every single penny. And when we met on the 5th of November, there was no clear winter plan that you had actually given to the hospitals. There was no clear strategy. What on earth is actually going on?
So again, just want to reiterate the point about how unacceptable it is for those patients to be suffering that way. Thank you for your thanks to the teams. That it's really important, because actually when you're working on the front line, it's an incredibly pressurised environment, and hearing this sort of narrative is very difficult when you're trying to manage the patient in front of you and manage the risk that's in front of you as a clinician. So that's really important for our teams. We are continuing to work, and John may want to come on this, on our rapid handover. We want to make sure that we can offload patients as quickly as possible. We have teams at UHL that are looking at all those patients in the back of an ambulance to see which ones can come off as quickly as possible. What we do have, though, we have a very pressurised emergency department, is a balance of risk between adding additional patients into the emergency department. So the flow through the hospital becomes really important, including discharge as well. We do have the Miami unit, which is our urgent treatment centre, actually on the site there, and we are in the middle of plans to look at our urgent treatment centres across LLR overall, and to make sure we've got a really strong city urgent treatment centre, as you, I'm sure you're aware. I think what's also really important is to recognise that the East Midlands Ambulance Service are looking at mechanisms themselves to see how they can optimise the lack of conveyance. So yes, they do have a very low conveyance rate, but actually by using the services in the community, they could go even further with that, and they are doing work to do that. So we call it see and treat or hear and treat. So they can manage patients over the phone sometimes, passing on to the service, or they can manage them in situ when they've gone out to the patient's home to manage that. So we are doing everything we possibly can across all of that. I want to just make a point that and John's made this point, that we've had those plans all the way through, that it's not that we didn't have those plans. What we've done is recognising the pressure that we had and not having any central funding come down for winter, which we have had in former years. We have taken on steps to put additional interventions in place. So the plan has been there, it's always been there, but because of the demand and the pressures we've had, we've put 10 or more additional interventions in place. So they were additional to the plans that we already had planned earlier in the year.
Thank you, Nilesh. John, did you want to come in?
Thank you. Just 3 points linked to that. So thank you, Councillor Hack. Recognise the points you raise. We work incredibly closely with EMAS, and I do recognise at times delays at UHL do lead to delayed response into the community. And I'm very sorry for any impact on patients there. Just to be clear on a couple of link points. So one is we don't have any beds not open as a trust. So while we reference our financial challenges, it is not stopping us opening our bedded capacity. Would I be making a case for opening more if we had more? Yeah, I would, in truth. But that speaks to some of our challenges more broadly than that. We also recognise, as Neil has said, our need to review urgent treatment centre provision across Leicester, Leicestershire and Rutland. And that probably speaks to the earlier point about coming back with those medium-term plans. We will recognise there is more we need to do on that front.
Many thanks for all of your questions and for John and Nilesh attending. We're going to go to item 9, UHL Future Hospitals Programme. Okay, this was going to be for Ben Teasdale, but maybe John could give us an update on the UHL's programme.
Thank you. If I'm very honest, I was not expecting to do this. Is Ben not there, is he?
Ben is not here, no.
Might I ask?
We're going to go and see if he's waiting in reception.
Yeah, if we could go to the next item, I will do the update if Ben's not arriving. I'll give Ben a call.
Yeah, all right, lovely, thank you. Okay, in that case, we will go on to East Midlands Fertility Policy, Case for Change, and I believe that's Joe Grizzle, Senior Planning Manager for ICB. There you are.
Thank you, Joe. It's actually Neil that's going to take this one, but I'm happy to help with any questions.
Yep, thank you, Joe. So this is really to brief the committee on a report really about our case of change for engagement for fertility. So across the East Midlands, we have differing policies on the management of fertility. And so what we are trying to do is to undertake an exercise to align those policies to improve the equity of access to fertility treatments across the East Midlands. So the engagement exercise opened on the 11th of November and it will run until the 10th of January. So it's absolutely crucial that colleagues and wider public contribute to this. We really want the broadest set of views that we can to inform the policy development. As different integrated care systems came together, there were some elements, particularly in Derbyshire and Nottinghamshire, that were quite different in the way they were providing access to fertility treatment. I think for LLR, there's probably less of an impact on some of this potential engagement and case for change than other parts of our East Midlands systems. But actually, it's really important that this is an equitable process. So you will see in there in the appendix a detailed set of proposals that are being considered, which include things like gender, body mass index, smoking status. It's really important to understand that actually this has been done with a specialist public health team. So these aren't plucked out of the air. There are absolutely factors that affect the effectiveness of fertility treatment. So they are not just exclusion criteria, as it were. They are trying to ensure that when we are funding fertility treatment, which does require considerable resource, that we are optimising the success of that fertility treatment. But this is about making sure this is equitable across the East Midlands. In terms of agreement on this, obviously after the engagement process is complete, recommendations will be made. The East Midlands Commission Group will come together, but individual integrated care boards will have to take a decision on that agreement and that recommendation. If there's anything else you want to add, Joe, to that?
I have a question on that. Why are we not following NICE guidance of 3 attempts? There is, many evidence across the UK about the 1 attempt, but in the southeast of England, they're offering 3 attempts. Why are we not following NICE guidance?
Yeah, it's a good question. NICE guidance is just that, it is guidance. So integrated care systems have the ability to interpret that guidance as they see fit for their population, but it's also in the wider context of all of the resources that we're trying to provide. It's a bit like the conversation we just had about urgent emergency care. These things don't operate in silo. We have to consider our total resource and how we can use that most effectively and most cost effectively for our population, and there are other competing demands. What we want to do is make this really equitable to the population, and so that our citizens are getting good access to that. But actually, we also have to consider the resource implications. You will see in the paper, NICE guidance has really significant resource implications that do need to be taken into consideration. But this is why this is an engagement. It's really important that our public get to advise us on how they think we should be spending healthcare resource across the system.
Councillor Hack.
Yeah, I just wanted to check, what's the financial implications for the ICB on making this decision? How much money are they going to actually save?
So this is not about making a saving as such, this is about aligning a policy. As you'll see in the proposals, actually, our policy is very close to the recommended East Midlands policy, so the implications aren't so great as for other parts of the system. I don't want to jump to any conclusions because we haven't had the engagement yet, so it will depend on the different factors and different criteria that we come down to decide upon. So at this point in time, this is an engagement. There's no implication from this engagement exercise, but it will depend on the outcomes of the engagement and the recommendations made thereafter. To go back to the point about NICE guidance, that would have a significant resource implication if we were to adopt that.
Thank you, Nilesh. I've got Michael Charlesworth.
Thank you, Chair. Yeah, it's nice as equity now across the East Midlands, or will be equity across the East Midlands, hopefully, with this engagement. But despite the NICE guidelines, it would be nice if we had equity across the country. End the postcode lottery and everybody gets the same level of service. Whether this committee can write to the Secretary of State or whether you can try and influence that, whatever would be useful. But that's the place where we should be.
Thank you, Michael. Are you making that as a recommendation?
Either through this committee or through the board. Somebody needs to say something.
I think both would be good. That's okay, Nilesh, and if we can put that on the recommendations. I've not seen Ben, so we'll go on to water fluoride. I can't say that word. Fluoride. Yeah, that's the one. Where are we? And it's Liz Rodrigo. Mike Sandys is we just lost, but I'm sure Liz can take this.
Yeah. Thank you, Chair. So we've been asked by the committee to reconvene. Oh, Mike's come back in, so I'll let him do it.
We have Mike. Just let Mike grab his seat and we'll kick off.
Apologies, Chair, I was assuming 10 minutes or so and then another agenda item to go. But there we go. I've probably missed by way of introduction. I won't summarise the paper in any great detail. Only to remind the committee that this came about as one of the byproducts of the conversation, the item on dental access, where the committee were interested in fluoridation. So hopefully the paper is fairly straightforward. It sets out, from a public health point of view, what we would see as the benefits of fluoridation. It sets out the current kind of legislative framework, which is basically, it's no longer a local authority decision or cost to fluoridate. It is something where we would petition or otherwise lobby the Secretary of State for them to consider the issue and to potentially launch a public consultation, which then might lead to the Secretary of State deciding to fluoridate water. And then lastly, in terms of the paper, we just give a kind of update on the position across LL&R. Liz, I'm sure, will cover the Leicester City position, which is supportive. Rutland, as you've seen the paper, had a full council motion last Thursday, which was passed in favour of fluoridation. Leicestershire is still just going through internal discussions, so hasn't got a position on that one at the moment, although I would hope to have that clarified by Christmas. So on that note, I will probably end there and open up for questions. Before I do, Liz, can you just remind me, in terms of the Leicester City position, you're supportive of, but you haven't written to the Secretary of State yet, because of course that would be best done on as big a geography as possible.
It's best to go on as big a geography as possible. So we're awaiting the decisions in Leicestershire and in Rutland. We're also waiting the outcome of the North East consultation, which concluded, and we're still awaiting for the Secretary of State to come back with what the outcome of that was. It's expected, it's at the end of the year. It's not much the year left, but we're still awaiting it. And we're also waiting because Nottinghamshire and Nottingham have also submitted to the Secretary of State, and we're waiting to hear whether they will be able to go ahead, and if they do, then that will result in a consultation across Nottingham and Nottinghamshire, and it's then whether or not it would be better for the East Midlands to go as a whole.
Thank you, Liz. I believe Dan Harrison wants to come in.
Thank you. Yes, my view is I wholly support this. I can remember a very dear friend of mine as a member of Parliament, probably 30, 40 years ago, fighting that we shouldn't do this. But when you look at all the evidence and young children and what's happening to their teeth, it's complicated. It's more than probably fluidization of water. But I think we're at a point in time now where there's nobody produced evidence to say that we're all going to end up with serious other diseases by consuming it, which was really the old sort of thing it was based upon. Could this happen? Could that happen? But I think we're at a point where hopefully we will support this and work hard to do it, because the benefits are just way beyond, it's an absolute win-win, this is. And as I say, with children in mind, how it's affecting their teeth. There's other options and reasons, I know, dietary and everything else. But I think if a helpful hand could be guiding them in some way, it would be good. Thank you.
Thank you, Dan. We've got Trevor Pendleton.
Thank you, Chairman.
Yes, please respond, Mike.
Thanks, Chair. Thank you, Mr. Harrison. Yeah, safety was one of the things I think we should cover, not least of which because, of course, the incoming Secretary of State for Health in America has views about the safety of fluorides, expressed concerns about them. From that point of view, hopefully the committee would be allayed. There is studies which, in rats do show that fluoride can be poisonous. But, the thing being, what's the difference between a medicine and a poison? Well, it's the dosage. So those studies which kind of show if you give incredibly high dosage of fluoride to rats or to humans, yes, it has an adverse, have an adverse effect. From this point of view, as paragraph 12 sets out, even given the very low threshold for adding fluoride to things, even the water fluoridation is only 2/3 of that. It's 1 milligram per litre as opposed to 1.5. So in terms of heavily regulated, and what the evidence would suggest, yes, I would agree with you. I think it's a safe measure that we could do. It'd be the single best measure for improving oral health that I can think of.
Thank you.
Thank you, Mike.
Thank you, Chair. And Mike, I totally get that, and I'm amazed that in 40 years, the report states, we haven't had any additional fluidisation measures taken by any other authorities, despite the fact that they've had the ability to do so, which really surprises me. And now it rests with the Secretary of State. I'm only frankly hoping that the Secretary of State will agree those applications that they've got in front of them now, because I would hate us to be wasting our time, effort and resources, which all those imply when we're very stretched at the moment, to get a negative and for the whole thing to come crashing down. So my question is, are we timing sufficiently well to take this without extending ourselves and our costings too far in case we can't get any further? And then what's plan B, please? Because I'm fully in favour of fluoridisation at 1 milligram per litre. And right, Mike, that's it. As far as I'm concerned, we should be having it. So what's our plan B if this does fall down?
Thank you for your question. Yes, and I think we are all
Dan,
concerned.
could you switch your mic off?
Yeah, thank you for your question. I think, yes, we are all concerned about spending a lot of time on something that may not come to fruition, which is intentionally why we're waiting for the Secretary of State's response for the North East consultation, and also their response to their application from Nottinghamshire. So we're not at the moment doing anything. We're just holding our breath and waiting. Once, or if this comes into fruition, it will take 5 to 10 years. So waiting a few months, we are not going to lose a lot of ground anyway. So that's why we're holding, as I put it, holding our powder dry at the moment.
And then just to add to that one, I'm sure West Region's got a number of other things on his list at the moment, assisted dying probably being top of the list for this week. I'm led to believe, talking to officials in DHSC, that it was one of those ones, it's on the list of things that have been discussed, but I'm not quite certain. It feels like things are moving within DHSC. Coming back to your point about cost, if you like, again, some of this might be interesting to see the view of Treasury, because to some extent we get a bit of a free pass on this one, in as much as 18 months ago, before the Act changed in 2022, it would have been a local authority decision to fluoridate, and actually we'd have borne the cost of fluoridation as well, which was not insubstantial. Certainly, I think for Leicestershire, outside of the infrastructure costs that the water industry would have to put in place, the mere cost of adding fluoride would have added about £400,000 to the public health bill, and obviously our grant's only 27 million. So I mean, that would have been roughly what, 5-ish% bill on top. Now that we essentially can say, well, we can choose whether we think it's a good or bad measure. Dear Secretary of State, can you look at this and take it further? The cost implications are not our concern, but I'm sure there'd still be Treasury concerns, and the cost of that's there. So I'm sure there are conversations going on between Treasury and the Department of Health in relation to fluoridation generally. North East is probably the test case. In terms of Plan B, I suppose the answer is Plan B is what currently is our Plan A. So if you look at what we do around oral health promotion, supervised toothbrushing, working with dentists to make certain they're applying teeth to the children eligible for the fluoride varnish, that's the work that the teams across Leicestershire, Rutland, and indeed Leicester City would be doing. We know that has, we've had some success in that one. It's not that long ago that I think Leicester City had the worst oral health in the country. Leicestershire's was not as good as it should have been, given our relative affluence, if you like. But I think I've referred to it again, and Liz, apologies if I've got this wrong. It's good news to move from being bottom of the table to being roughly on the fringes of the relegation zone, but it's still not really kind of where we should be heading for. So what we've done, I think, has helped, but there's clearly issues in terms of how much we can do within public health using those measures. And then there's the inequalities angle, which again comes down to those that are able to buy fluoride toothpaste that are able to sort of supervise their children, otherwise kind of give those good parenting skills, are probably more successful. than those parts of the population that can't. So again, at least with fluoridation, it is to quote George Osborne, a rising tide that floats all boats in this case.
Thank you. Michael Charlesworth has a question.
Well, more of a statement really, but possibly a question in here. Yeah, I think we need to get all our eggs in one basket and make the biggest case possible for this. I agree with Dana. This is good. I know there are concerns. I mean, Public Health England did a report 6 years ago on fluorosis as a result of fluoridation in water. I think it's also called dental mottling, but I don't pretend to know much about it. We had a report at the recent committee. It showed the problems in young people and teeth. I mean, fluoridation occurs naturally in this country for about 1/3 of a million people. So all the case studies are there. Another 5-6 million are getting fluoridation in this country and hundreds of millions around the world. The case is there for it, but I agree. We get it all together, Nottingham, Derby, East Midlands, North East, get it all together, back to the Secretary of State and move it forward. But like it says, it seems to be a bit of a long trek, but we need to make it happen. Thank you.
Thank you, Michael. I'm going to come over to, did you want to come back, Mike?
I can never resist the temptation, even with a statement, to respond to it. Just on mottling, is an interesting one. I mean, mottling can occur. It is one of those things that happens with fluoride. Even at these levels, I think it probably is important to say that actually it really shouldn't cause mottling in adult teeth, but it might do in children's teeth. Of course, you lose your children's teeth, so any mottling would be, it would be kind of short term, if you like, within children. And completely off piece. I hope my wife's not watching. I may or may not have had a former girlfriend who had received, when they were younger, the dentist for some reason gave them kind of fluoride bath in the mouth, and that did cause fluorosis into adulthood. So again, it can happen, but it comes back to that's the difference between a tightly controlled adding it to water supply and a dentist for some bizarre reason in the 70s and 80s kind of going, the good thing for you is to go and just have neat fluoride pushed all over your teeth. So these things do happen, but it shouldn't happen with this scheme, if we pursued it.
Thank you, Mike. I'm just going to go over to Phil King.
Yeah, thank you, Chair. I've got a question I want to ask first before I want to make a comment. So what I want to ask Mike and the other medics here is this: if we go ahead with this, if this goes ahead and we have fluoridization of water at the level that you're talking about, what impact does that actually stop dental decay 100%, or do you still get dental decay happening? What difference does it make? And that's what is not presented in this paper. And so I'm just trying to understand that before I say something else. Thank you.
Liz.
Yes, it's inevitable there will still be dental decay, but this will reduce quite a lot of the inequalities across the system. We've got dental decay in much larger numbers in parts of the community, and hopefully this will, level that out. We'll never stop all dental decay. Some of that is reliant on what people are eating, drinking. Carbonated drinks in particular have a big effect on what people's dental oral health is like. And as does the amount of sugar that we eat now, which is very different maybe from when I was a child. So there's more exposure to more risks, I think. So this is sort of trying to halt some of that.
And just on that one, and again, I was just reading through the paper and I've left my laptop over there, unfortunately. In terms of the evidence base, there is a briefing paper we can circulate, which I'm sure some members, certainly Leicestershire, might have seen before, which, coming back to the point of what difference does it make, it would be in there. It would make a difference, doesn't eliminate it. But yeah, there's good evidence in terms of the percentage, if you're comparing non-fluoridated with fluoridated areas. But for accuracy, we should circulate that with the minutes.
Chair, if I could just come in on this point, actually. I was going to wait till the end to comment and ask questions. But just on this particular points, I've got some of the studies in front of me. Public Health England, that doesn't actually exist anymore as a body. In 2014, there was a 45% reduction in hospital admissions for 5-year-olds due to dental decay. looking at the national picture and a 20% overall reduction in tooth decay in 5-year-olds? Answers your question, Phil.
If I may, Chair. Thank you, Ross. Thanks for that. So look, that's great. Thanks for answering the question about it doesn't eliminate tooth decay, although it helps to some degree. And fundamentally, then that comes back to my answer, my comment on this. So reasons for tooth disease, tooth decay are complicated. They're generally due to people not brushing their teeth and ingesting substances which are decay their teeth. And if you're a child, that's the decisions as to what you put in your mouth are generally due to a older person buying products, food, drinks, which you consume. And if you're an older person, then you should have hopefully by then have understood that drinking lots of carbonated drinks or whatever else it is you do has a detrimental effect on your health, your teeth, dental health. So to me, I'm not entirely convinced by this, and the reason I'm not convinced by this 100% is it is about freedom of choice. It's about my right, and that's a very important right. I appreciate there are colleagues here who don't like to think about that, but it is about freedom of my right not to have products added to my water that I don't wish to consume. I'm not saying that's the case. I'm just saying there are residents who will say that. And I think that's a very important thing, because there's lots of other things we could do, add things to people's food or drinks to make them healthy, and we don't do that. So I'm, and to me, the real issue of this is this just going to is this going to make any difference to behaviours? Is this going to change what people do? They don't brush their teeth. They don't use toothpaste. They don't, they continue to drink carbonated drinks, sugary drinks, whatever. And the answer is no. It is going to make no difference. In fact, actually, it could, for some people, give them a false sense of security because they'll say, oh, it's okay. I've got fluoride in my water, so I don't really need to worry about that. And there's a danger in that. Now, I'm not saying it is definitely the case, but I'm just, I just think this is more nanny state knows best mantra, which is obviously some people are very keen on. I'm not so keen on. I'm not saying it isn't a good idea, maybe, personally, but I just think there are some concerns about this, which, would be the same for any other thing where it was about adding a product to your water or your food. To make, and I appreciate there are products added to food, vitamin supplements and things like that. So it is, but then people have a choice as to whether they buy those products or not. Whereas water comes through a tap into your house and you don't have a choice unless you end up going and buying bottled water, which by its very nature, a lot of it is fizzy and has carbonated substances in and even more additives. So there's no easy situation.
Can we let Mike come back on that?
That's fine. I just wanted to say I'm not entirely convinced. I didn't say I was against it. I'm not entirely convinced. Thank you.
So I suppose that comes back to there's a couple of things in there, at least a couple of things in there for me. One of which is in terms of process. And again, it's easy for me and as public health professionals to say, what's the best thing we can do to improve the dental health of children and adults access to fluoridation? But there are issues in there which people may have concerns around safety. Hopefully we've addressed those. And the other one is people's attitudes towards state intervention, sometimes known as nanny statism. And so I think it's important then to realise that, again, it's not supposed to be kicking the can down the road, but there will be things the Secretary of State needs to weigh up, as I'm sure they are in terms of the North East consultation. And then the other bit is realising that if we did support it, if the Secretary of State did then consult on it, that's the point. There would then be a public consultation which would address, some of those attitudes, which I'm sure he would bear in mind. So I think it is a valid point to raise, and I suppose the reassurance is it's built into the process as we go along to do that. In terms of behaviour change, that's almost a separate item. I was just looking at Liz. I think both city and county and Rutland would be working on a whole systems approach to obesity, if you like, because actually there's many things, if you look at, as Liz said, around consumption of sugary drinks that would alter those. I would argue, yes, people are free to choose, but actually I'm not certain that's a fair fight if you look at the amount of advertising and product placement and everything else. Again, it's an entirely separate argument, isn't it, around obesity? But when you're then looking at a stage where 2/3 of the population are either overweight or obese, and you look at how that's increased in the last 20 so years, either the whole population has just suffered a collective collapse of willpower and education, or something else has been changing our attitudes behind our backs, if you like. So there's a whole different point. And then lastly, I think you touched on this at the end. Yeah, I don't wish to get into a debate around attitudes towards state intervention, but you're right. It's there are things that do have things added, vitamins and cereals, obviously. There are things that I would argue actually you don't get much choice about, such as adding folic acid to bread in terms of reducing neural tube defects in unborn children. So I think so. Anyway, as a point being for me, I think it's a complex picture and almost needs to be considered around in terms of public's attitude towards state intervention, which the consultation would take account of. But if you're not to know this,
Thank you, Mike. I'm going to come to
Thank you.
Councillor Ross.
Thank you. I've got two points I'd like to raise. I'm going to assume that for this purpose that the Secretary of State does approve it, and this relates to public consultation. In the debate that we had in Rutland, there were a couple of academic papers that were referenced, one from the University of Florida and one from a university in Australia that just escapes my mind at the moment. But I do think that in terms of informing the public on it, it's important that we do actually recognise these alternative reports that are out there. The second question relates to timing. A number of councillors in Rutland visited the wing water treatment works last year, and as you're aware, there is an existing fluoridation provision within that facility. And it was really whether we believe that, I think Liz hinted that it might be possible to bring it in earlier than 10 to 12 years. Thank you.
apologies for the university challenge style. We just it's going to answer as well. No, shall we say?
Friend.
Phone a friend. They have. We're just. I mean, the question I was just asking Liz. Actually, you're getting into the detail then of almost individual plants and whether the infrastructure is able to do it. I mean, you know, there are some households already that up in the northwest of Leicestershire. There's some in Melton. There are some in Rutland that do receive fluoridated water either naturally or because their catchment areas go into it. I suppose the quick confer is I really don't know at this stage. If you took a map of all the water treatment plants across LNR, which ones would need infrastructure upgrades to enable it in the way that Wing does and which ones don't. But you're right, that doesn't mean that if LLR was minded to then petition the Secretary of State, if the Secretary of State was then minded to go and launch a consultation, the next stage would be looking at the detail of how quickly could we bring it in, what would be the infrastructure upgrades and the rest of it. I suppose that's the level of detail which is sort of, we haven't quite got at the moment.
I think also part of that, after the Secretary, if the Secretary of State said yes, there's a feasibility study that has to be undertaken by the water companies. For Leicester, Leicestershire and Rutland, we're mainly Severn Trent, except some Anglia in, I think it's Rutland. But it would be beholden on those water companies to actually undertake the feasibility study.
Thank you, Liz. I'm going to come to Councillor Hack and then I'll come to Trevor.
Yeah, I just want very quickly, I just wanted to add, there's 40% child poverty in Leicester. A few years ago, there was a big problem with scurvy, and they were talking about adding vitamin C, and they were also to bread and to add vitamin D to milk for rickets. What it's, you know, the reality is this will only solve the problem of the teeth, but not the rest of the body. And we've already heard that paediatrics is a big challenge in the A&E department, and I get the case for fluoridization, I get that, but we really need to look at the overall health of children in Leicester in particular. given the child poverty rate, given the fact that we know other illnesses are occurring. We've even had TB at a high level in the city. All of these are problems that are fundamental, and there doesn't seem to be anything that is addressing these problems, because you're dealing with what's going into the mouth because of the teeth, but actually what's going into the body and the rest of the problems that occur with that. We've got to have a serious plan to deal with that as well.
Liz.
Yeah, thank you, Councillor Hack. As in public health in Leicester, we have quite a big programme of public health interventions that we're undertaking. So we're working very closely with LPT for work with young children to look at what they are taking in their diet, working with health visitors. We also have a big programme of working with supervised toothbrushing in primary schools and in nursery schools. And what they're doing is not just looking at the supervised toothbrushing, they're talking to the schools about what's in the diet, what children are taking in their lunch boxes, various things like that. So we are looking at some of those things, which also goes into looking at things like breastfeeding, encouraging breastfeeding amongst mums so that children get a really good start in life. So there is a whole programme, which if you like, I could send to you, if you would like that.
Can I just add, child dentistry has been an issue in Leicester for the last 15 years, and we've failed consistently. Both councils failed consistently to deal with this problem. And now the cure is fluoridisation, which I get, but it means that we have failed, and we should have been better at actually dealing with this problem earlier, because we've had 15 years of knowing this problem is there, and we're still one of the worst in the country.
Liz.
Yeah, that's why we're putting in place all of these programmes at the moment, including the supervised toothbrushing, encouraging people, giving out kits for toothbrushes and toothpaste in various areas, including in food banks. So we're trying to really target the areas of most need with some of those things. With regards to access to dentists, that's beyond what we can address in public health city.
Although I'm reminded that does bring us back full circle to the previous report on dental access, and I suppose it does come back to the kind of why now. And for me, again, some of the why now is, I think, that was the discussion we had at the last committee around dental access was, as you say, we've not, there's an intractable problem around dental access, particularly in the city, around the NHS. So coming back to comments about Plan B, maybe that's that's why maybe it's gone up the list of things that we need to consider.
Thank you. Trevor.
Thank you, Chairman. Well, I've heard the debate here already start, and the debate seems to centre around I have a right not to have the state tell me what I'm to drink, eat, and everything else. But a right equals a responsibility, and you have therefore collectively failed in your responsibility to some extent. And it's very difficult, when you go down that route and you start wagging your finger at people, and you say, well, 20% we could improve cavities or lack of cavities by 20%, and that's fantastic. And I can't understand why anybody would say so. I will not accept fluoridisation. It just beggars belief as far as I'm concerned. And the final thing, on a slightly happier note, Liz, I do hope, and Mike, I do hope that when we give our children the brushing and the toothpaste, it is with fluoride in it. Thank you, Chairman.
Thank you.
Yes, the toothpaste that we give out in our supervised toothbrushing programme and also in the food banks, it is fluoridated toothpaste, specifically for the reason that it provides some protection.
Thank you. Just going to go a little bit out of sync. Come to Councillor Payne and then you, Ross.
Thank you. I just want to throw in a word of caution here, because when we had our meeting in Rutland, we were at great pains to say that we were only looking at it in principle. I don't want
this to appear that we've already made a decision. This is not a done deal, certainly not in Rutland, and I suspect nowhere else. There has to be a wide area of time of public consultation. The public's views have to be given weight, not poo-pooed because they're just the public, and we know best, which we don't, clearly, as there's been many examples of that. So I'm just slightly concerned that we seem to be going in a certain direction. And whilst I think it's right and proper that we advise the public, I don't think we should be to a point where we're appearing to make a decision on their behalf and then asking them simply to ratify it. I don't think that will go down very well.
Yeah, and it's not lost to me because I think the debate's been really useful, but again, it does come back to kind of almost what are we asking for? And the debate is around, as you say, the principle of fluoridation, given the oral health that we've got across LLR. But it comes back to, the discussion here, the views of the three authorities would then be to almost then say to the Secretary of State, actually, we think for good reasons or bad reasons, whatever, this is why you need to then consider it. But it is for the Secretary of State to then go through that process of consulting with the public and then deciding on the back of the consultation what they would do. Important to recognise the consultation, I think, in the legislation says it's not a referendum, but nonetheless, the Secretary of State would be beholden to give due weight to the views of the public within the consultation. So, it's not within our gift to fluoridate the water. It is within our gift, if the three councils are so minded, to ask the Secretary of State to then consider that and take forward the views of the public as part of that.
Thank you, Mike. I'm going to come to Ross.
Perfect. Thank you, Chair. And, I was minded, given my background, to let other people talk first. But I just wanted to put a few comments out there. I think it's important as well to appreciate the context in which we're talking. So, I think 1 in 4 children starting school with dental decay doesn't sound like that much. But if you think about the knock-on impact that has on that child, we're talking about speaking issues, eating issues, lack of confidence, missing school attendance days. I think it's about 3 or 4 days on average a child misses school because of dental issues. They then go into the referral system, they have a general anaesthesia for tooth extractions, they're then scared of the dentist because of all of that experience with the hospitals, and it has a knock-on effect later in their life. So whilst 1 in 4 children starting school with dental decay might not sound like a big issue, it is, for the individual, it is a huge problem. I think also, it's very wise to consider what else is the plan, and we've spoken about if this is plan A or plan B or even plan C. And as Mike said, it goes back to the first item that we considered on the agenda. We know that the population in which we are serving is getting more medically complex, disease levels are going up, and NHS resources are getting more scarce, more scarce. And we will all have residents who will contact us about struggling to get in to see a dentist. And so I think unless we do everything that we can to try and improve that, I think, to be quite frank, we're being a little bit hypocritical. If you look at the return on the investment as well, from the studies that I found that I referenced earlier, to put it into context again, for every £1 that we invest, Public Health England estimated that within 5 years would save £12.71, and within 10 years would save £21.98. And again, I was looking at the studies earlier. Currently, this year, dentistry is the second greatest cause for children 0 to 18 being referred to hospital. So at 5 years old, general anaesthesia of tooth extraction is the number one reason 5-year-olds are sent to hospital. But even in 0 to 18 for the entire gamut, it's the second greatest cause of referrals behind ENT. I think there's very pertinent points there around personal choice. I think it echoes, sort of vaccination debate that we've had after COVID. And as the study refers to, or the paper refers to, there's probably not that much evidence we've got out there for what is the public opinion on fluoridation and where are we at. I would have thought they're thinking retrospectively, they've had water fluoridation in Birmingham for 50 years, and we've all got friends and family in Birmingham. And when was the last time you spoke to them and they said, do you know what's really getting my goat? My water's fluoridated. I don't think anyone's ever even mentioned it. It just is what it is, and they don't have issues with it. And I think Councillor Charlesworth, you mentioned the mottling as well. Again, from my Birmingham friends, they don't seem to have any worse teeth than anybody else. I've not noticed any brown marks or things like that on their teeth. Coming back to the other comments from fellow councillors, I appreciate Councillor Hack's comment on the frustration of the position that we're in, especially in Leicester, and maybe a lack of progress that's been made. But I think there's no time like the present. And even if this is going to take 5-10 years, well, for me, that's not going to start it as pronto as we can, at least start the ball rolling to that position. And finally, I've got to disagree with something that Councillor King said earlier when he said, decay is a complicated thing. Actually, in essence, it's not really. You have too much sugar and you don't clean your teeth. And that's it in a nutshell. Yes, there are influencing factors. There's deprivation that influences on those sorts of things. But you said also you've got concerns that we're not asking residents and the children to change their behaviour to improve this. But for me, that's the beauty of it. We all know, I know personally that I could lose some weight. I should go to the gym. I should eat healthier. But I probably don't do it as much as I should. We can tell these children that you need to brush your teeth more and have less sugar. It's a very, very simple message, but it's not happening, is it, really? And so for me, that's the exact beauty in this proposal is the fact that we're not asking them to change their behaviour. Just keep on doing what they're doing. Finally, I know this is a scrutiny panel, so I'm supposed to ask questions, not make a statement. So I've got 2 questions to finish off with. One of them is around the effect that everyone wants things to be natural these days. And I would point out that I highly suspect that the water we receive through our tap hasn't just been imported from rainwater or whatever. I'm sure these water companies are adding not bleach, but all sorts of other chemicals to make it safe. I don't know if we have any comments on what they're adding there. And the second comment is I completely appreciate the process. I think it's very, very wise to wait for a response to the North East consultation on fluoridation. There's no point putting all our eggs in this basket and then it's a wasted effort. We know, though, that the Secretary of State is more likely to approve a proposal if it has wider support. So I'm minded, have we had conversations with Nottingham and Derby? And depending on where the pipes underground go, is it possible to join up with them? I know they're slightly more ahead in the conversation than we are, but tackle it from a wider standpoint.
Technically, I'm not certain about that one, but I think as Liz referred to, and as the paper refers to, the bigger the geographic area that is presented for the Secretary of State to consider, the better. And from that point of view, the Nottingham and Nottinghamshire have declared their support. They've written to the Secretary of State. I understand Lincolnshire and Derbyshire are considering it. Obviously, we're going through our processes here as well. So regardless of infrastructure, it would be nice if it were to happen that it would be done on an East Midlands footprint. There's a complex beast in there of several local authorities all coming to a decision and then working out how to do it. But that would be the intention. But I think we equally need to keep tabs on the likes of, say, Derbyshire and Lincolnshire, because that really would then potentially, if we got to a position of LLI was supportive, that ducks are being lined up in a row. But clearly each individual authority needs to make a decision on that. I'm also, sorry, just to go back to your point about purity of water, I haven't got any figures on that. I'm just reminded of something I think my brother said to me once, which was London's water is the purest out because it's been through 5 people's kidneys before it gets to you. So there you go.
Thank you, Mike. Cash from Health Watch wanted to come in.
Yeah, I've just been sent messages about a couple of things. The dental recovery plan not doing too well, as we already know. It's not solving oral health quickly enough. A bit of an alarming figure. According to the BDA, 96% of dental practices are not accepting new NHS patients. I could probably tell you loads more, but we know. Medical evidence is sort of saying there's a strong case for fluoridation. The public has their say, and it's not necessarily based on medical evidence and the chances of success, but human rights and stuff. Now, Health Watch would be the first organisation here to be saying, consult. So when a feasibility study has been done and when the public consultation happens, we don't at this stage know what sort of results and how strong a case the public are going to put forward to accepting or not accepting fluoridation. My question is, what have we, fluoridation, the idea is not new in Leicester. It was talked about many, many years ago, Leicester, in the Leicester area. And so what have we learned from any previous consultations? What have we learned from other regions consultations in terms of what the British public generally sort of go towards?
Liz?
I would probably say very little because there hasn't been that much consultation yet about fluoridation. The consultation in the North East is complete. We're waiting for the Secretary of State to announce what that was. So hopefully before Christmas, we will have a bit more of an answer about that. What we do believe on some surveys that have been done, that about 60% of the population are in favour of fluoridation, and about 16% of anti-fluoridation. So it's really, we don't know what our local population is like because it may differ from that. So I think we're going to have to wait until the consultation for the North East has been published. Whether Nottingham and Nottinghamshire are allowed then to go to do their consultation, which the Secretary of State carries out, we don't carry it out. And then we'll get a better idea of what the feeling is in the public.
Thank you, Cash. I mean, as a councillor in Leicester, for me, this is a typical case of health inequalities and deprivation, and lack of dentists as well, that makes it very difficult. But, you know, I mean, look at the health benefits of the smoking ban in 2006, or was it 7? That was massive, you know. But I think we're wise to wait for the North East financially to see what they get. Okay, I'm going to roll back to item 9, UHL. This was in your supplementary agenda pack, which was circulated, and we've now got Ben Teasdale online. So take it away, Ben.
Apologies, Chair, for not making the meeting earlier. Miscommunication around diaries. But anyway, obviously I'll talk briefly to the report and then take questions. I'll begin with just talking about the new hospitals programme and then come on to local schemes that the Our Future Hospitals team are managing. So from a new hospitals programme perspective, no news is good. Good news, I think, is the best way of saying it. So obviously we presented in July that that the government were going to undertake a review of the new hospitals programme, and there was concern as to where that would lead. That obviously was an internal review, so the new hospital programme was not put at risk by that. That concluded shortly before the Chancellor stood up in the House in October. So what was announced was that there was going to be an increase in £22.6 billion to the NHS budget through to 25-26. And that was for a variety of different elements in terms of improving clinical capacity, reducing waiting lists, and adding 40,000 new NHS appointments. But it did allocate funding to the new hospitals programme for the first time as part of that. What we don't know is how much money of that 22.6 was allocated to the new hospitals programme, and we don't know where we sit in the timing of that programme. So we do expect Wes Streeting, Secretary of State for Health, to announce further detail about how that £22.6 billion will be spent, and then hopefully either in the new year or maybe even post the next budget in March, we'll understand about where our place in the programme is and what our allocated funding is. The good news is that we continue to be asked to progress at pace with our programme. So we are in the middle of our SOC delivery, aiming to deliver our strategic outline case by February next year. So in the meantime, we continue to meet with the New Hospitals Programme as part of their progressive development programme and the ongoing work of New Hospitals Programme in terms of developing their Hospital 2.0 strategy and design, and procuring a main works partner for the programme continues. So I think that's as far as we're at with that. I think, if you permit me, let me just go on to the live projects and I'll take questions about everything at the end. In terms of live projects in construction, is the first would be East Midlands Plan Care Centre, and that's due to open in I think 10-11 days now, on the 9th of December. We're in the final stages of commissioning of that building, and staff are busy unstocking and cleaning and preparing as we speak. With regards to the endoscopy unit build that I advised on the last time we met, that progresses. It is now actually in part construction. There has been delays in the programme around the preliminary stages of the build, and it's due to now be operational in August 25. Then the only other element to mention, which isn't technically part of our programme, but to make everybody aware, is obviously the Community Diagnostic Centre will also be opening on the Leicester General site, and that's due for opening in March 25. So that concludes my report.
Thank you, Ben. Are there any questions? No questions here, Ben, so I'm sorry. Oh, sorry, Councillor Hatt.
Hello, Ben. How are you? You're right.
Yeah, very good, thank you.
Good. I just wanted to ask a couple of questions, really. Originally, there was a pathway plan back in 2003, 2004, and that was originally started off at about 700 million. Then it went up to 850 in 2005. Then it went to 600 in 2007. And then we had this new reconfigured sort of project in 2019, which was promised by the then government, £450 million, part of Boris's new hospital projects. That was 450 million. So do you know how much money roughly you're going to get? Because what was envisaged in 2005 won't get you anything in comparison to what you're paying now, because the build costs have almost doubled in that time frame. And does it look likely that we'll get a new maternity unit? And that was one of the sort of big features that Leicester's desperately needs, because there's been a couple of reviews about maternity services and nothing's changed.
So you're right that a lot has changed, and I can add to that in terms of the New Hospitals Programme requirement for the new buildings to be carbon neutral, for the buildings to be fully digital, and so on and so. And oh yeah, pandemic proof with 100% single room. So there's a lot of change in those requirements. What I can say is the New Hospitals Programme is very clear about what our preferred way forward is as an organisation, and they have been appraised of the costs of constructing that, as they are aware of all other hospitals in the programme. So we are just waiting, like all of those hospitals, to see in what order the New Hospitals Programme, and ultimately, I mean, the New Hospitals Programme have an idea about how they would like to do it and in what order, but ultimately it's a political decision as to which hospitals go when, and what the funding envelopes are. So I think to reassure everybody, we have been very clear about what it is we want to build and what we want to do in those buildings and how much it will cost to construct them.
Sorry, just as a quick follow on, look, I know lots of people in Leicester and Leicestershire who live here, particularly work in the NHS. Lots of them work at Derby, Peterborough, Coventry. They've all got brand new state-of-the-art hospitals. If you go into any of those hospitals, I've been to some of them recently, and I was just amazed to see how beautiful and how sort of almost like a five-star hotels they are. Does that impact on us attracting people and retaining people, staff? Because staff is so crucial in the whole of, in the 17,000, 18,000 staff that work at UHL. Is that a major factor in getting people to come and work at Leicester?
Yes, And I think it forms the part of any business case in terms of there is always a benefits analysis in there, and the recruitment and retention of staff forms part of that in terms of any reasoning behind the approval of funding for doing something like that. It also sometimes attracts more patients, so with those elements are all taken care of it in the business case process. So we're at an early stage in terms of needing to submit a strategic outline case. What does make our scheme and our hospital advanced in to some element is we've already consulted. So the consultation is an ace in the hole from a UHL perspective, from a region. But as I said, we are just literally in a holding pattern whilst still producing the work that we need to progress as soon as we know that we're able to.
Thank you, Ben. Ross, did you want to come in?
I did, yeah.
Councillor Ross.
Thank you. Thank you, Chair. My questions are follow on to the questions from Councillor Hack. The 450 million scheme that Councillor Hack referred to defined a particular scope of work, and my background's in construction. I want to be clear where we are in terms of fixing the design against which the monies are going to be given, because we have been at this process for a long time. So where is is it now a design worked up to a stage where it can be immediately put out to tender? Thank you.
The simple answer to that, Councillor, is no, because to do that you have to have completed a full business case, and to complete a full business case you have to be given the permission to proceed, and you have to be given the money to develop that. So again, we're not able to progress beyond submitting the strategic outline case, for which the New Hospitals Programme has given us permission and money to proceed to at pace, and we're not able to proceed beyond that until we have approval from the New Hospitals Programme.
Thank you, Ben. Phil King.
Thank you, Chair. Thanks, Ben, for a bit of a lion's den, I think, for you this morning. So what I'm going to say is this. The last time I was at a meeting of the Joint Health Scrutiny, the scheme had been put on hold then by the then government because they were doing what's called cost engineering, and you hadn't got the green light then, and that's got to be 2 years ago, nearly, where you hadn't got the green light to go forward with your full business case. Then since then we've had the general election. Now, new Secretary of State has said he's going to increase NHS appointments in the NHS by, well, actually, if you work that out over 2 years, it's an extra 55 appointments per day across the whole of NHS England. Unless that's 40,000 new appointments a day, I didn't think it was, but 55 appointments a day across the whole of NHS England is not a great increase in the number of appointments, quite frankly. And it's actually very, very minor, really. What's concerning, and I think Mr. Hack and Councillor Ross over there have made similar points, which is basically this is delay upon delay, and we've had a period of high inflation that's added to costs of everything, and what that means is what you're going to get for your 450 million is a lot less than what you thought you were going to get when you started this process 2019. So what's that, 5-6 years ago? We actually started it before that, but when you finalised the consultation during the pandemic. So I think this is concerning, because at the moment I don't actually understand what you're going to get for your money, for our money, and you just explained, Ben, that you've had to add in certain factors into the design of all the new programme, and correct me if I'm wrong, but you said they're going to have to all be 100% digital enabled. They're going to have to be infection proofed for another kind of pandemic outbreak, and there was something else. But when I remember seeing the original consultation, what we had, it was lots of expensive to maintain curved glass frontages to buildings, which I remember commenting on the time to the project team, who's going to pay for the maintenance of those things, because curved glass is A, very expensive to put in, and B, very expensive to keep maintained and repair. So I'm still very concerned about this, the ability for it to be delivered. And all I can see at the moment, you're talking about you won't even possibly, in paragraph 5 of the report, you say that you might not even get a decision until after the March budget next year. So that's just even more delays, which is just going to rack up the costs. And yet what we've got, as we heard earlier, is fundamental problems with the configuration of the health service in Leicester and Leicestershire, which has a day-to-day impact on the ability of our fantastic A&E emergency services to actually deliver a first-class service to residents and taxpayers of Leicester and Leicestershire and Rutland. And, it just goes on and on. So I'm just really concerned. What is it we're actually do you think you're going to get for your money? B, what can we do to put pressure on the Secretary of State to actually get on and make a decision too sweet? Because this is just, we've been at this, as Mr. Hag said, 20 years plus, probably longer than that, I think. We cast our minds back and look in the archives. So I'm just concerned, what we can do now to make this actually happen. Thank you.
So if I could just briefly come back on that. So the £450 million that were announced in 2019 was pre the new hospitals programme. So in a way, we have to separate that slightly, because that amount of money was indicative of the plans as part of our 1,800-page pre-consultational business case that was submitted. With the invention of the new hospitals programme, that has changed the environment in which everybody is constructing and building hospitals. So as a consequence of which, the budget that we think we need to build these buildings does not resemble that 450 million, and the new hospitals programme are very aware of that. And those other elements that I talked about in terms of pandemic proofing, 100% single rooms, carbon neutral, those are all filtered into the cost estimates that we are submitting as part of our strategic outline case, as are things like industrialisation targets and Hospital 2.0, which will actually reduce construction costs, both in terms of time and overall costs. So what I can say is that the hospital and the team have been very clear in explaining to the new hospitals programme in terms of how long we've been at this, and that has been recognised on several occasions by the central team, and they are aware of our preferred way forward in what we intend to construct and the cost of that. Having said all those things, we, like 40 other hospitals, are currently in a holding pattern and are as frustrated as each other and everybody in the room, I suspect. But up until that, the good news is that new hospital programme did not get canned by the Labour government when they came in. The review was actually an internal review, and in the meantime, we have not been stopped. We've been asked to progress our strategic outline case at pace. So I think we're as the best place we can be at the moment, although I do completely accept the frustration in terms of the delay. We feel it as much as anybody else does. But up until that point, we just have to wait.
Thank you, Ben. I believe Nilesh wanted to come back.
Just a really quick point to say, I think you've outlined the risks really clearly, Councillor King, actually, and your support as a committee would be very much appreciated. Going back to previous discussions about productivity and efficiency of our pathways, estates is really fundamental for us, and it's not just emergency care, it's maternity services, it's children's services. So your support as a committee would be very much appreciated.
Yes, Phil.
Yeah, I mean, to be fair, I'm not having a go at you guys. I'm just trying to understand what we can do here to make this happen. But if I just pick up what you just said, Ben, you said it's not a £450 million project anymore. So, and I'm inferring from what you said, is it more than that? Is it less than that? And what I'm still not clear about is what are we actually going to be getting anyway? You know, what is actually on the table in this program now? Because it's gone on a few years. I'm still, you know, you talked about things have changed. So what can we be absolutely clear about what it is we're actually proposing, or you're proposing, is actually going to be included, and what's no longer included as we understood from 2019? Thank you.
I would be happy to update the councillors at the next HOSC meeting after the Secretary of State has made an announcement. But I can confirm that the sum of money that is required is substantially more than 450 million.
Thank you, Ben. Councillor Hack would like to come back for the
very
final
quickly. I just
question.
wanted to make a recommendation. Can we write as a committee directly to the Secretary of State of Health and Social Care and make the request that we get as much money as possible? Because seeing as we have lost out time and time again over the last 25 years, and the Leicester and Leicestershire population has been forgotten, we've got hospitals that are way past their sell-by dates, and we need change. So could we do that as a committee? Is that okay?
That recommendation's very good. And with that,
Rutland to that.
and Rutland, yes. Thank you. Thank you for everybody who has attended today and all of the presentations. Our next meeting of the committee is scheduled for Monday, the 17th of March, 2025 at 2 p.m. And I'll draw this meeting to a close. Thank you.
Thank you.